IV started. So there's things you need to do in order to get ready to do that. First, you need to look at your patient and decide why they need the IV. Maybe they're going to surgery, maybe they're elderly and dehydrated. So you need to decide what equipment you're going to need, because the doctor will tell you the fluids that you need, but he will not tell you normally the size or gauge of the IV. That's something that's up to the nurse's discretion. So first, let's talk about the sizes. And it's important that you remember the color coding of it. Now, I don't have a yellow marker, so notice that the yellow is kind of a mind game. It says green. But for the most part, in the clinical setting, there's going to be 4 different colors of IV start kits or IV needles that you're going to use to start, and they're always color coded. And these colors are universal across all the U.S. If you go into a patient's room and you look at their IV and you see that the end of it is blue, the hub of it is blue, then it's going to be a 22 gauge. If you see a green one, it's going to be an 18 gauge. So again, the smaller the number, the bigger the needle. So an 18 gauge is always going to be green. A 20 gauge is always going to be pink. A blue is always going to be 22. Blue 22, kind of rhymes. And that's what you've got in your kit. And a yellow one is going to be a 24 gauge. Now you may see some orange and gray ones. I think they use the 14 gauge when you donate blood, and they're either orange or gray, I can't remember. But those are rarely used in a clinical setting, in a hospital setting. 18 is the usually go-to, especially the trauma patients get those, because those are the bigger the needle, the more fluids they can push into you rapidly. So 18 gauge is green, 20 pink, 22 blue, 24 is yellow. 24, the yellow ones, you see them in maybe the elderly, you see those in children, someone that's got very fragile veins. There are some key determinants that, for example, that you have to know. Say your patient's going down for a colonoscopy. That means your patient has got to have at least a 20 gauge in to go to surgery. To go to surgery, you've got to have at least a 20 gauge. So you can have an 18 and a 20 in any patient going to surgery, because that's in case of an emergency if they need blood. Say they're doing, let's say a gallbladder surgery, and they nick something, and you've got to have a blood transfusion right then. Blood can only be transfused through a 20 gauge or an 18 gauge, because the gauge of the needle is big enough that it won't destroy the red blood cells. You cannot give blood through a 22 gauge or 24 gauge. So when someone goes to surgery, then you automatically know you have a 20 gauge or an 18 gauge in that patient. But if, say, your elderly patient is dehydrated and they need some fluids in them, you may not be able to get an 18 gauge in them. You'll probably be able to get a 24 gauge in them. And that's fine as long as they're not going to surgery. But if you have someone going to surgery or getting a blood transfusion, you automatically know that you have got to have at least a 20 gauge in them. Looking at my notes here. Tubing. Whenever you're starting IVs and you're doing your tubings, or even if you're doing heparin locks or saline locks or the intermittent devices, that's where they essentially just have the little needle here and you're not connected to a pole and a lot of fluids. You still have to rotate IV sites every 72 hours. Now, if it infiltrates or gets phlebitis in it, of course, you have to take those out and immediately start a new site. But if it's all going good and your patient needs an IV for like a week, you still have to rotate those sites every 72 hours to prevent them from getting infected. Tubing, I believe the book says that tubing is changed every week, like regular tubing is changed every week, but most facilities follow the 72-hour rule. Because if you're changing the IV sites, you might as well change the tubing as well to prevent infection. However, if a patient's getting TPN, that tubing is changed every 24 hours religiously. And whenever you open tubing and start new tubing on your patient, you always date and time it with your initial, of course. So, a few more things since I've got it on my board. Pumps. Most things require a pump. Some things don't require a pump, but there are things that absolutely require an IV pump to run it. You can't just drip factor it in or use your roller clamp to drip factor it in. If your patient is on TPN, That means it has to be on a pump, with a pump watching it. If you're giving a patient like a cardiac med drip, it has to be on a pump to help you administer that. If someone's getting blood, it always has to be on a pump. If someone is getting potassium, it always has to, or an IV fluid with potassium in it, it always has to be on a pump. But if you're giving someone just like fluids for hydration, even antibiotics don't have to be on a pump. Of course, you're watching them and you're watching the drip factor and having to count or using the dial-a-flows. But in these cases here, always have got to have that pump going. Of course, pumps are cleaned in between each person. You cannot take one pump to another room without it going, usually in a hospital, through the central sterile and being thoroughly cleaned. Because even as a nurse, you've got to be sure to wipe these down, because a lot of times patients are using these to steady themselves to walk to the bathroom, or they get handled a lot. So you want to be sure that these are not switched from room to room without being properly cleaned. Now let's talk about the different types of tubing. So, and again, the doctor's not going to tell you what type of tubing to use as part of nursing judgment. If you have got a pediatric patient, say you're working pediatrics, or you have a child, or even some elderly adults that you do not want to overwhelm them with fluid, you would use what's called a Buretrol. And I'll unwrap these in a minute. If you're giving blood, blood is always given with Y tubing. And the type of fluid that you only give with blood, if you're hanging blood on a patient, or as an LPN, you will not be hanging blood, but you may be monitoring it. Blood always has to have 0.9 normal saline with it. No other fluid can be given with blood but 0.9 normal saline. Secondary tubing, or your piggyback tubing, is needed if you're going to hook an antibiotic in with that patient's primary line, and of course your primary tubing. There is such a thing, it's called sub-Q infusion tubing, and it is a tubing that you would use, or it's really a needle too, that if you've got some elderly patients that you cannot get a 24 gauge on. You just cannot get an IV line started in the vein because they're so dehydrated. You can do fluids sub-Q and put the IV fluids directly into their fatty tissue using a special needle. You infuse it really slow, usually less than 50 cc's an hour. And maybe after they have that, maybe the doctor's order just 1 liter of fluid for them. And if you can't get a vein, and you don't want to just keep sticking and sticking and sticking someone, because it's best if you can't get the IV after 2 attempts, you need to let someone else, because you don't want to stick someone 3 times for an IV. So maybe, especially your elderly people, a sub-Q infusion could be given to them to kind of get them plumped up and better hydrated versus trying to dig for a vessel. And then your dial-a-flow. A dial-a-flow is a set of tubing that has got like a manual clamp on it that allows you to set the rate. Again, it's not a pump, so you can't give these on them, but you may see dial-a-flows used a lot in long-term care, even in emergency rooms sometimes, if they don't have a pump. Because when you don't have a pump, you're at the mercy of gravity, you're at the mercy of the patient bending their arms as to how fast the medicine runs in. And a pump is set, and it has alarms, and it will alarm you when something's not right. So we're going to do what's called spike and prime your IV tubing. By spiking and priming, that just means you're going to take the spike and you're going to put it into the IV bag, and by priming it means you're going to flush all the air out. So the doctor is going to order your IV fluids because it's considered a medication, and you have to know how to go into the med room and pick out the right IV fluids, because they're not the same, and you will have a whole chapter over that. There's isotonic, hypertonic, hypotonic, and you want to be sure that you are using exactly what the doctor has ordered, or it's considered a medication error. So I have got here D5 half normal saline. They usually come in crinkly bags like this, and a bag of IV fluid is good for 24 hours. This fluid is good for 24 hours. So let's say I was running this at KVO, which is keep vein open, at 20 an hour. In 24 hours, there's going to be a lot of this left over, so I would need to throw it away. Or if I knew it was going to be running that slow, instead of getting a 1,000 ml bag, I would get a 500 ml bag. That way there wouldn't be so much waste. So this is D5 half normal saline, 1,000 mLs. D5, 0.45 sodium chloride. So when doctors orders it, he'll order D5 half normal saline, which is what this is, 1,000 mL. You always check your expiration date, and you always look at your bag. If there's looks like there's any sediment or it's discolored, or if it's out of date, of course you would not use it. Now there may be a little moisture from condensation on the inside of this bag. That's all right, because it may be a little sweaty. But if you see a lot of fluid in here, or if it's discolored, then you would not use it, and you would take it off the shelf. So I'm gonna open my bag, and I'm gonna hang it. Okay. Now, I'm gonna need a primary line. So let me find my primary line. This is my primary line. So this is my primary tubing that is still in date. It's good. Oh, and this is an older set. When I open my tubing, the first thing, it always comes with a little paper wrapper on it. The first thing you always do is close that roller clamp, because it all comes open. So you close it down to the small end, because if I spike my bag without doing that, all the fluid's going to run out, and it's going to get on the floor, it's going to get on your clothes and make a big fat mess. So just personal habit, before I tear that piece of paper off, I close that roller clamp. Tear this off. Now you want to do this with clean hands. Of course, I've washed my hands, but you don't want this to touch the floor. You want to be sure that you keep the parts sterile that need to be sterile, like this end part here. When I take that blue cap off, that end part has to remain sterile. And I'm going to open up my tubing without it touching the ground. Now, again, I've got my roller clamp closed. I have got, you don't have to have this, there's other little clamps on it. Like, usually these little clamps are used for the pumps. And that's one of the tricks with pumps, is each type of pump has got special tubing. So it can be very expensive for a facility to change out pumps, because when they change their pumps out, they got to get a whole new kind of tubing. So this tubing is not going to fit this pump. So I'm just going to show you for the heck of it. But a lot of times, a lot of the new pumps use this little clamp as the key to get into the new pumps. Of course, this is the part that's going to attach to the patient. And then along the way, you see little ports. There's usually one down close to the patient. There's one up a little bit higher, right there. The pump would go usually above the roller clamp. And then there is a port above the pump. There's also some that this one's got a little filter built in along the way. Then here is the drip chamber. And then this is the spike. So we've got our clamp closed off. We're going to, now our IV bags have got two ports here on the end. It's going to have one here with like a little port that you could put a needle in if the pharmacy needed to add medication to the bag. Of course, if you were going to add medicine to the bag, it has to be labeled and date and timed and the whole 9 yards, but we're not going to do that. And then we got the blue port, and we're going to pull this off. Okay. Now when I've got that pulled off, I cannot touch this with my finger like that, because this has to be sterile. Okay. Now I've got my spike, and remember, we're going to prime the tubing, because this has got air in it. You don't want to hook this up to the patient and then turn it on, because you would flush about probably 7 or 8 mLs of air into the patient and cause an air bolus and could kill them. So that's a no-no. You don't do that. So you take your spike cap off. So you see your spike. You're going to hold it down. And you can do this down here if you want to, but I've got it hung up, so we're going to do it this way. You're going to take your spike, and you've got to hit it dead on. If you hit it like this, you've contaminated it. And this is going directly into the patient's bloodstream, so you do not want to do that. So you're going to hold it, and you're going to spike it. You're going to push it in, and that little point will break a seal in there. So I've got it spiked. Then I'm going to squeeze my drip chamber. See how the fluid's coming in it? So I'm going to squeeze it and fill it about halfway full. You don't want to fill it too full because you want to be able to see it drip to be sure that it's working. It don't matter about air bubbles in that. So now, this has got fluid in it, but the rest of the tubing has got air. So we have to prime our tubing. So I'm going to put my roller clamp in my hand. I always have a garbage can because now you can watch it flow through, but I don't want it to shoot the floor because it gets really messy because this has got dextrose in it. And dextrose is essentially sugar, so it'll be a little sticky and make it weird. So I always have a garbage can. Then you want to, now if you'll watch, when I let go of my roller clamp, you're going to see it start to drip. You see it dripping? You want to do it slow because you don't want any air in the tubing. Now I can watch it really slow through here, and then it's eventually going to come out the end of my tubing. Should start to drip. See it dripping? So I have got it, all the air out of my line. And to be sure, I'm going to check my line to be sure there's no big bubbles or anything, because I did it slow. So now, I could go hook this to my patient. I'm going to date and time it. I would put it in the machine and be sure my machine is working, but again, this doesn't fit. But I have primed my line with my fluid. And that is how you spike and prime a bag.